Pelvic fractures. Published by WordPress.com. Clinical evaluation of pelvic injury. Polytrauma patient. 1Y survey. ABCDE trauma. Second survey. Whole lower limb. Hemodynamic. First clot is the best clot, large in pelvic bed, most of clotting factors consumed inside, on HGE time till recent. You disturb it with dilution, washing or extra fluids. APLC test, ant. Post and lat, compression. Look, massive buttock HGE. Feel, ant. Pubis, post. SI separation. Move, limb IR, PV and PR. Signs. Limb length discrepancy, LLD, internally or externally rotated limb, anterior-posterior, AP, or lateral compression tests. Skin. Scrotal, labial, perineal swelling, flank hematoma, degloving injuries, Morel-Lavalley lesion, perineal lacerations, Camoli sign. Neurological. Lumbosacral plexus injuries, especially at L5 and S1. Urogenital. Hematuria, vaginal, and rectal examination. Open injuries. Check sphincter tone and floating prostate. Imaging. X-ray. Anteroposterior, AP, inlet, 60 degrees caudad, and outlet, 45 degrees cephalad, views to assess pubic rami, iliac wings, sacrum, and SI joint stability. Oblique views for acetabular fractures. CT. Used for posterior ring fractures and signs of instability, SI displacement greater than 5 mm, posterior fractures, avulsion of sacral, ischial spine. Published by WordPress.com. Pelvic fracture classifications. 1. Young and Burgess classification. Anteroposterior compression, APC, symphyseal diastasis or longitudinal rami fractures, anterior SI ligament disruption, open book injuries. Lateral compression, LC, transverse fractures of pubic rami and posterior injuries. Vertical shear, VS, symphyseal diastasis or vertical displacement, often involving the sacroiliac joint or iliac wing. 2. Tile classification. A. Stable fractures. B. Rotationally stable, vertically unstable. C. Rotationally and vertically unstable. Management of pelvic fractures in polytrauma patients. 1. Initial management of hemorrhage. Pelvic binder, sheet wrapping. Applied at the level of the trochanters to help control bleeding and provide access to the abdomen. Military anti-shock trousers. Utilized in the field to stabilize the patient before reaching medical facilities. Pelvic C-clamp. Ring stabilization to reduce pelvic ring instability. External fixator. Used for resuscitative fixation or definitive fixation of anterior pelvic injuries. ORIF. Open reduction internal fixation. If the patient is undergoing laparotomy, ORIF may be required. Open packing of retroperitoneum, when there is significant hemorrhage in the retroperitoneal space. Angiography and embolization, used selectively to manage identifiable bleeding sources. 2. Definitive treatment. Conservative management. Indications. Anterior, isolated. Symphyseal diastasis less than 2.5 cm with intact posterior ring. Isolated pubic rami fractures. Method. Partial weight bearing for up to 6 weeks. Operative management. Indications. Hemodynamic instability. X-fix. Vertical instability. Rotational instability. Open pelvic fractures. Open book fractures greater than 2.5 cm. Sacral displacement greater than 1 cm. SIJ disruption greater than 1 cm. Leg length discrepancy greater than 1.5 cm. Methods. External fixation. Indications. Resuscitative fixation and definitive fixation for anterior pelvic injury. Pin placement. ASISAIIS iliac crest. ORIF. Open reduction internal fixation. Anterior and posterior ring fixation, using recon plates and screws. Indication for bilateral posterior unstable disruption. Sacroiliac screw lumbopelvic fixation. And 3. Complications. Neurological injuries, particularly to the lumbosacral plexus, L5. Urogenital injuries, including posterior urethra and bladder injuries. Thromboembolic complications, DVT, PE. Mortality, 15 to 25% in closed fractures. Hemorrhage risk, increased in older patients, age greater than 60, and those with high injury severity scores, ISS. Hemodynamic instability, requires massive blood transfusion and stabilization. Associated injuries, head, chest, and abdominal injuries can increase mortality and morbidity.